Just before we start, I just wanted to tell you that last night I got a phone call from the head of HRSA, the Health Resources and Services Administration, that sort of runs all of the community health centers across the country and our teaching health center program, asking me if he could come and visit us next Friday. So he's going to be here from 2 to 5 o'clock in the Harlem Family Health Center. So I'm sort of putting you all on notice. And I'm going to be putting us on notice multiple times. This is really, it's a treat because he doesn't get out that much. And so the fact that he's chosen our program to come and visit is pretty special. So I'm really excited about that. And we'll be getting a draft agenda from him as to what he wants to do. This morning, we're going to be discussing a very important topic. As many of you know, we've been very receptive and very eager to be serving people post-incarceration, and yet understand that there are risks that we need to learn more about in relationship to especially people returning to opioid use. And so it's a great pleasure to be able to introduce Dr. Jonathan Giftos, and I'll read his bio. He's Clinical Director of Substance Abuse Treatment for the Division of Correctional Health Services at Rikers Island, where he oversees diversion, harm reduction, treatment, and reentry services for incarcerated patients with substance abuse disorders. He's also Medical Director of the Opioid Treatment Program for the New York City jail system, in which he also provides clinical care, including the provision of Methadone and Buprenorphine maintenance treatment to incarcerated patients with opioid use disorders. Prior to this role, he served as Director of Clinical Education for CHS, where he developed curriculum, provided clinical supervision, and supported the educational goals of medical students, residents, and attendings caring for patients affected by the criminal justice system. He's also a voluntary attending in the Bronx Transitions Clinic at Montefiore's Comprehensive Healthcare Center in the South Bronx. Dr. Giftos earned his medical degree at Mount Sinai. He completed residency and chief residency in the Primary Care and Social Internal Medicine residency program at Monty. During his training, he also completed a Harvard Macy program for postgraduate trainees, where he developed skills as a clinical educator. He's credentialed as an HIV specialist through the American Academy of HIV Medicine. His professional interests lie at the intersection of addiction, incarceration, and public health. Situated in the jail system, he collaborates with community health centers like us, academic health centers, and the New York City and State Department of Health to advocate for justice-involved patients with opioid use disorders. We're very happy to welcome you here and look forward to learning from you. Thank you.
So it's great to be here this morning. Thanks again for the warm welcome. As Dr. Kalman said, I actually went to medical school here, and it's really nice to see how family medicine has really has grown since I was here. Some of you may know I started in 2008. At the time, family medicine was a division of internal medicine. A year later, it was completely phased out, only to come back as a much more robust Department of Family Medicine. And so I trained in internal medicine, social internal medicine at Monty, but I was a big family medicine sort of champion when I was here, and I think that had I trained during a different era, I would have been a family doc. So it's really just great to see that thriving here.
Red Tech can still come back and do another Red
we're applications are out.
Yeah. So it's really good to be here. Today I'm going to talk to you a little bit about returning from incarceration and reducing risks of reentry for people with substance use disorders, in particular opioid use disorders. And the talk should fit within the time with some space for questions at the end. I know it's early and many of you have to, I imagine, run to clinic. So, but I'll leave my contact information if anybody has any questions. So I have no disclosures. I'll use generic names whenever possible. And what we really hope to do today is really go through the harms of incarceration for people with opioid use disorders, describe barriers to care for people transitioning back out of correctional settings, and appreciate and leverage the role of reentry organizations in supporting patients' healthcare engagement during the post-release period. So perhaps not surprisingly to many, criminal justice exposure is very common for patients with opioid use disorder. This is in part due to the fact that for those who use heroin, it's a sort of daily task of buying and using something that's illegal to possess, to use, to sell. In addition, though, as we know, patients with opioid use disorder over time develop tolerance to opioids such that the amount of opioid they need to use on a daily basis just to feel normal and relieve withdrawal symptoms can get very expensive. And so we surveyed patients in the jail who have an opioid use disorder. The median number of bags a day of heroin they're using is about 17. And with a bag of heroin between $5 and $10, you're talking about sort of $100 to $200 daily that needs to kind of get turned over. And so it requires, and it often leads to patients having to do things illegally to afford their use. In one study in England, looking at patients that were voluntarily entering residential drug treatment for an opioid or cocaine use disorder, 47% of people disclosed that they had committed an acquisitive crime, which is sort of the technical term we use for any illegal activity to acquire substances in the 4 weeks preceding admission to residential treatment. And that's people treatment seeking. So you'd imagine that patients that are not treatment seeking or that are in areas that are policed more heavily are going to have even higher rates of exposure. And in a study of patients actively in office-based buprenorphine maintenance in Baltimore, 40% of the patients, approximately 40 of the patients enrolled in treatment had at least one criminal charge over a 2-year period. So it really kind of walks along with having an opioid use disorder in the United States. Criminal justice exposure really could mean many things. Working in a jail system, I've come to realize that many people sometimes don't always know the difference between a jail, a prison, being on community supervision. So I just wanted to briefly walk through that. So I work in the New York City jail system, predominantly on Rikers Island, though there's facilities in the Bronx, Manhattan, and Brooklyn. Jails are local. They're usually county-based in places with not a lot of population density, or city-based in really big cities like New York and San Francisco. The majority of people there are there pre-trial. So they haven't been convicted of anything, and they have a lot of uncertainty about the disposition of their case. For those that are sentenced in city jails, they're serving a 1 year or less sentence. And that's about 15% of the jail population in New York. The key word for jails is flux. The next key word is chaos. So no one knows when they're going home. If you go home, its majority of them are unplanned releases. Bail paid, warrant lifted, they go to court, and charges are dismissed. So reentry planning is really difficult out of jails. Prisons, on the other hand, are where people tend to serve sentences of 1 year or more. They're largely state, with a small percentage of people in the United States in federal prisons. But the majority of people are in state prisons. And they tend to have a little more stability, though they do move people around a lot in New York. And they have a known release date. So there's a little bit more intentionality that can be around planning for reentry. Community supervision is an umbrella term for things like parole or probation. Probation is often in lieu of any sort of sentence. Parole is often after a sentence has been served. It's a continuation of your sentence in the community, so you're still under supervision, and you're at very high risk of getting sent back into custody for small technical violations of the terms of your release. So knowing about your patients that are on parole can be really helpful. So opioid use disorder in the New York City jail system is really common. It's common everywhere in the United States. In the last year, there was 8,000 people that passed through the jail with an opioid use disorder out of a population of 50,000 that churned through. So the prevalence, snapshot prevalence in the jail at any given point in time is about 17% of all patients in the jail have an opioid use disorder. And when we surveyed people with an opioid use disorder, 58% had been incarcerated 11 or more times. So it's not just a one-time exposure for many people, it's sort of a chronic recurring exposure, especially for people with substance use disorders. And incarceration confers on people with an opioid use disorder very specific health risks that are really important to know. Withdrawal, untreated, disrupted treatment, and then overdose risk, they're all driven primarily by a lack of access to evidence-based treatment while incarcerated. And so as I talk through some of these risks, they're going to vary across the country based on the extent to which people have access to evidence-based care while they're incarcerated. So for those of you who have cared for people with an opioid use disorder, you know that heroin withdrawal sort of starts to kick in a few hours after somebody's last used, and it sort of peaks within that first day. And then it can linger for many, many days after, even if treated. There's a phenomenon called post-acute withdrawal syndrome that can linger for weeks to months that put people at very high risk of return to use. When people are arrested in New York City, they don't immediately get brought to a healthcare worker to assess their health needs. The process in New York and in many places is that you're first in NYPD custody, you're brought to the precinct, you're searched, things like that. You get your arrest charges by NYPD. Certain types of charges then are going to bring you before a judge. You're going to meet a public defender often. The prosecutor is going to see your case. You're going to go before a judge and you're going to get arraigned. Arraignments happen in New York City till 1 in the morning every day in every borough. So if you ever want to go watch arraignments and just see the sort of churning, it's a really good educational experience. We actually had an elective. We have an elective for medical students, and we had Sinai students actually rotate with us, and I took them to see arraignments just to sort of see what it's like to kind of go before a judge. But what happens in that moment is that if the prosecutor requests bail, and the judge accepts bail, and the patient can't afford bail, they're then transitioned from NYPD to DOC custody. Once they're in DOC custody, they then have 24 hours to be given a bed. The last 4 hours of that 24 hours is in the clinic where they're getting a comprehensive medical evaluation. So from NYPD arrest, if it happens on a Friday night, and they're in the precinct till Saturday morning, then they get brought to see a judge on Saturday, then they're transferred over on Sunday. It could be Monday before the person is actually seen by a clinician. So the sort of intensity of heroin withdrawal is really going untreated for sometimes 2 to 3 days. So it's a very high risk time. And in some places around the country, this drives very dangerous. So we often, in training, you'll say benzo and alcohol withdrawal can be fatal, but heroin withdrawal is just uncomfortable. That, I think, is a limited frame for thinking about untreated heroin withdrawal, because untreated opioid withdrawal drives really risky use. It can also drive people to, in some places, to be so dysphoric and despairing that they take their own life. And in a small jail in Massachusetts, they had a series of suicides in custody of patients that were undergoing untreated opioid withdrawal. So it's a major risk factor for risky behavior. The second risk of incarceration really is disrupted treatment. And so I like to sort of poll the audience when talking about this, but if we think of severe opioid use disorder, moderate to severe opioid use disorder, and the standard kind of gold standard of care being access to opioid agonist therapy with methadone or buprenorphine, if patients are on those treatments and they enter the jail system, what percentage of U.S. jails or prisons will continue those medications for people while they're in custody? So just raise your hand if you think 80%. Raise your hand if you think 30%. Raise your hand if you think 10%. Raise your hand if you think less than 1%. So no one said 80, which has happened before, but it's actually less than 1%. So there's about 5,000 correctional settings in the United States, and really only about 40 offer agonist therapy, and it's not even like full access. Many places will only continue it. Some places won't start it. Many places provide buprenorphine, but not methadone. Some places will provide both, but it's very rare to have full access to treatment. So it's very, very common for patients to enter into custody and have their treatment really disrupted. And Aaron Fox, who's a colleague of mine at Montefiore, did a qualitative study of patients that had been stabilized on methadone maintenance who were passing through correctional settings, asking what was it like to sort of pass through the correctional setting on an agonist therapy and have it disrupted. And sort of the take home of the study was that it was so unpleasant to be denied access to a treatment that they were on that it led to a post-incarceration aversion to ever wanting to go back on agonist therapy. So for a whole generation of people, we've sort of burned their experience with methadone maintenance because we've been unable to provide consistent access to it at different sort of stages of their life. This is really a harm, I think, of incarceration that goes unnoticed. The last major harm, and there's many that I won't be able to address, is overdose risk. And while we do see overdose in correctional settings, people with opioid use disorder that have gotten access to opioids, there are overdoses that occur in correctional settings, but it's the post-release period that's really thought of as being the highest risk time for patients. There's a really sort of often quoted seminal study on this by Ingrid Binswanger that looked at people coming out of state prison facilities and found that the post-release period, the first 2 weeks, were a time of increased risk of dying. 11 times increased risk during that time, driven largely by overdose risk during the reentry period. And the sort of, the conceptual framework for that is that these are patients with an opioid use disorder who have been taken off of the opioid they were using. It hasn't been replaced with anything. They've lost their tolerance. They're in an abstinent state, thrust back out into the world without a lot of support. And if they use again at levels that they used before, they're at really high risk of a fatal overdose. So the question then is, does exposing, we often say, of course, provide people with methadone and buprenorphine because it's the right thing to do, it's humane. Why would you deny somebody's insulin? You shouldn't deny them their methadone. But does exposing them or continuing to allow them to have agonist therapy reduce post-release mortality risk? And this has been demonstrated in several large studies internationally. The most recent one in 2017 in England that looked at exposure to agonist therapy for people in the state, in their prisons and jails and returning to the community. It was a prospective observational cohort study. It included people in 39 prisons and about 15,000 patients. 8,000 or more were exposed to agonist therapy while incarcerated, and that was defined as any consistent dose of methadone or buprenorphine in a maintenance capacity, not in a tapering capacity. The median methadone dose was 40 in the study, and the median buprenorphine dose was 8. So these are not necessarily considered common or therapeutic doses of methadone, at least. And so these are just kind of basic initiation and stabilization doses. And the outcomes they looked at were all-cause mortality and then drug-related poisoning in the 4 weeks post-release. And they found that exposure to agonist therapy was associated with a 75% reduction in all-cause mortality and an 85% reduction in drug-related poisoning in the 4 weeks of reentry. So these medications, irrespective of the person's long-term plan for treatment and recovery, have been shown to be associated at least with mortality benefit in the 2 weeks post-release. So what about naltrexone? You may provide naltrexone to your patients or offer it as part of treatment for alcohol use disorder or patients that have co-occurring alcohol or opioid use disorder. You may have patients asking about it. In the criminal justice system, there has been massive uptake by naltrexone into jails and prisons. Massive. Often as the only therapy offered to patients with an opioid use disorder, and it's often offered as one shot as you're going out the door. There's some evidence, and you may be familiar with the evidence for naltrexone, that it, in some studies, there's been evidence of a reduction in rates of return to use as compared to usual care. There's no evidence of mortality reduction as far as I know, but the data is limited. And if you look at a lot of the data, and I'm good friends with Josh Lee, who's a big naltrexone researcher at NYU, and we've had lots of discussions about this. He did a large study in 2016 looking at justice-involved patients with an opioid use disorder and offering naltrexone versus usual care. But the inclusion criteria for the study were patients with a preference for opioid-free therapy. So not all comers. It was really patients that had expressed a preference to not be on methadone or buprenorphine. And we don't, so when you see a study that's enrolling people over years, and they enroll 300 people, or 400 or 800 or whatever. You don't know like how those people kind of represent the larger population. We had 8,000 people with opioid use disorder pass through the jail. When you have a study with a couple hundred people, is that really representative of all comers? And we can't say for sure. I can say anecdotally that I've only had one patient in 2 years ask me about naltrexone. And in the Rhode Island expansion, you may have heard that Rhode Island recently expanded in their unified jail prison to screen all patients for opioid use disorder on intake and offer all 3 therapies. Only 4 of the 303 preferred naltrexone at point of medical intake. So it's not clear to me that studies that recruit people with a preference for opioid-free therapy can be generalized to all criminal justice settings and to all patients. So offering it as monotherapy or only therapy in places to me feels like a misapplication of research data that is potentially life-threatening. So we've fully integrated methadone and buprenorphine into the New York City jail health system. We've had a jail-based opioid treatment program since 1987, so I take very little credit for this work. But we did do a pretty big expansion in the last couple of years, broadening inclusion criteria and trying to ramp up new initiation of buprenorphine in patients who are interested in it. So we treated almost 4,000 patients in the last fiscal year, and it's really the case now that about 75% of all people entering the jail enter off treatment, and about 75% now leave on treatment. So it's a really sort of, it's a big place for accessing agonist therapy. Despite, now this is a little bit old data, so I want to just give some context, but even we've had a jail-based opioid treatment program since 1987, but overdose death still remains the #1 cause of death post-release coming out of the New York City jail. This data is from 2011, 2012, so it predated both our expansion efforts, but also the fentanyl crisis in New York City, where obviously now we're having fentanyl-contaminated heroin. It's really increased overdose death rates in the last few years. So it's unclear if our expansion efforts plus the fentanyl overdose crisis, what our more current data is. We're currently evaluating it. But just to say that even in a place that had a jail-based opioid treatment program, overdose death remained the highest risk post-release. And when we looked at the 22 who died in the 4 weeks coming out of the New York City jail, 19 of them were not on any agonist therapy. And it's unclear, if that was because they preferred to not be on any methadone, or if we didn't get to them in time and they had a very quick incarceration and were discharged quickly, or if we had some inclusion criteria at that time that excluded them from access. But just to say that the people dying are largely off treatment. So coming out of jail or prison I sort of am kind of belaboring this point, but the reentry period is just a really high-risk time for patients, with overdose death being the most significant risk, but all sorts of other risks significantly heightened in that period. And there's a lot of reasons why coming out of jail or prison is really hard for patients. The first is a sort of technical and boring one, but one that I imagine many of you have encountered. Can you raise your hand if you've heard of the Medicaid inmate exclusion policy? So we got one tentative hand. So the Medicaid inmate exclusion policy is really driven. It's a federal policy that prohibits the payment of federal matching dollars for the cost of any services provided to an inmate of a public institution, except when the individual is a patient in a medical institution. So what that means is that if you're in a public institution like a jail or prison, the jail or prison is not able to bill Medicaid for services they're providing to you. They have to provide those services to you independent of Medicaid, because they're not going to get the federal matching dollars for the money spent then. Except if the person's in a medical institution. So if you're hospitalized out of a jail at Bellevue or you're sent somewhere else, you can bill Medicaid for those hospital services. So when you check someone's Medicaid status who's been incarcerated or is incarcerated, does anybody know what I don't want to pull the early morning, I'll just tell you. The insurance will pop up not as active, not as closed, but as inpatient services only. So inpatient services only in New York City and New York State with Medicaid is really a proxy for somebody who's incarcerated. And it's the state's attempt to suspend their Medicaid and not close it. So in many states, they just close out your Medicaid right away when you're incarcerated. New York has sort of trying to take a little bit more of a humane approach by suspending it. And then it has to get reactivated when they come out of jail or prison. And that process can be, calling HRA or going to HRA and they'll just turn it back on. You don't need to submit a new application for these patients. But it's, we all know nothing is easy. Nothing happens at the time that you need it to happen. And it just remains a big barrier for patients. So one of the take homes of any talk I give is inpatient services only really means they were incarcerated. They do have Medicaid. It just is suspended and needs to get turned back on. The limitation to having any sort of suspended or inactive Medicaid is you cannot back bill for meds dispensed at a pharmacy. So if you activate their Medicaid, you can back bill for services, but pharmacies can't back bill for something they dispensed before. Or at least this is what pharmacists have told me. The pharmacy kind of capacity to do things around this space varies a lot, but it's a limitation for many of our patients to access buprenorphine. The other big barrier which is not surprising, I'm sure, to many of you, is really trauma and stigma. Trauma is very common among justice-involved patients. This is just some example data from some papers. With high rates of childhood physical and sexual trauma and continuing adult physical and sexual trauma. Virtually all women who are incarcerated have had some degree of intimate partner violence. So it's extremely common to have experienced trauma. But trauma is more than violence, and I have come to really appreciate the way that other forms of trauma impact patients in the criminal justice system. So we know physical, sexual, emotional violence is traumatic. We know witnessing it is traumatic. But we also know things like abandonment, neglect, being separated from people can be very traumatic. We know that poverty, racism, traumatic experiences with the healthcare system, family members who struggle with addiction, all of those things are really traumatic for patients. And those traumatic experiences often influence the patient's health and health-seeking behavior. So you may have experienced patients who react to administrative challenges in clinics or news that you may not be able to see them at the time that you did, or that they're going to need to see a different provider in ways that feel more severe than you might have expected. And that is often because it's often influenced, at least, by trauma. And so a lot of the work around engaging and serving people in the criminal justice system is being really mindful of not re-traumatizing people through what we often will think of as sort of mundane administrative things that we do in our clinics. So trauma-informed care, which is, certainly I'm not going to do it justice in one slide, but trauma, I really just like to make the important distinction between trauma-informed care and trauma-specific interventions. So I think a lot of providers feel overwhelmed by this idea that if you've had trauma in your life, I am not equipped to sort of dive into that. I don't want to open it up. I don't know what I would do if you started sharing a lot of traumatic history with me. I'm not trained in treating PTSD, and this is the space of sort of experts. And I think that's important that there's a sensitivity to that. But I just want to draw a distinction between trauma-specific interventions and trauma-informed care. Trauma-informed care is really a global approach to people that's simply mindful of the way trauma impacts health and health seeking. And so the way we engage patients, the way our clinics are structured, can be trauma informed even if we're not trauma experts. So the SAMHSA has sort of put out the 4 R's of trauma informed care. The first one being realizing its wide impact and understanding its role in people's recovery. Recognizing signs and symptoms of trauma in patients. So when patients are having strong reactions or pushing you away or being afraid to open up because they're afraid to be vulnerable to somebody who may abandon them. These are manifestations often of trauma. And with the sort of being mindful of that, I think can help us to engage more thoughtfully. Responding appropriately by integrating the knowledge that trauma is a part of our patients' lives into our practices. And then trying to be mindful of avoiding re-traumatization. And I really think a lot of this falls in the space of the administrative practice of clinics, being available to patients when they need us, not being mindful that canceling appointments can be very traumatic for people. Switching providers can be traumatic. If you're going to be leaving a clinic, telling the person in person versus having them show up and have you be gone. These are kind of things I think that primary care is complicated, scheduling is complicated. There's no shortage of administrative challenges to preserving continuity and supporting the clinic's just general ability to serve all comers. But those administrative things can be real challenging for people with trauma history. Stigma 2, which is defined as a social process which can reinforce relations of power and control and lead to status loss and discrimination for those who are stigmatized. So I think a real practical and pragmatic word for stigma is discrimination. It really is not just political correctness or using the right word, but it's things that push people away or marginalize them and make them feel less than. And this is I'd just like to share this quote from Louis Jones, who is a person who used drugs, but is an activist for this work. And he said that stigma is the most harmful thing, even more than the drug itself. It's the emotional feeling that people have about themselves, how they view themselves, how they believe people view them. I think it's the worst harm ever. More than any drug that a person could choose to do, it's the emotional, internal feelings that they have towards themselves as a human being, as a person. And so there's a lot that we can do to reduce stigmatization of patients with substance use disorders, justice-involved patients. Words matter, and this has been studied, actually. So this is another great quote that I just like to share from another activist, Eddie Ellis. Words matter. They shape perceptions and understanding both of past and present events and of future possibilities, and therefore future events. Semantic and public acceptance of terms like formerly incarcerated or returning citizens, rather than ex-felon, ex-offender, or ex-inmate, are of fundamental importance to the process of public opinion formulation, positive media images, effective social service delivery, and most importantly, progressive policy change. So words have been studied, and they've been shown to influence the way that even well-meaning healthcare workers think about people and about the options to support people as part of their recovery. And so we avoid stigmatizing words like felon, ex-con, parolee, and we try to really encourage person-first language or people-first language, person who's been incarcerated, justice-involved patient, person on parole, leading with people's humanity and recognizing that the words we use can influence others' perception of who we're talking about. Just to quickly describe, I don't think I have a slide for it, but there was a study by John Kelly up at Harvard that looked at mental health clinicians and the way that words influence their perceptions of patients. They went to a conference with hundreds of mental health clinicians, and they sort of just randomly divided them. And to the 250 on one side, they gave a clinical vignette that described a substance abuser who was not meeting the conditions of a court-ordered drug treatment program. And in the other group, they described the patient as a person with a substance use disorder who was struggling to meet the conditions of their court-ordered drug treatment. And the group that got the vignette describing the patient as a substance abuser was more likely to recommend punitive responses to the person's struggle to adhere to treatment than the group that got the person described as a person with a substance use disorder. And we know that this is, individuals are going to respond differently to words, and that it really is not everybody in that arm was like lock him up and the other arm was like give him treatment, right? We know it's not, the effect size of those things is probably not enormous, but it is clear that language does have an influence over what we perceive of people and their and the options to support them. Just a quick note on urine drug screens. We at Montefiore, they spent a lot of time teaching us about urine drug screens and how to interpret them. But we didn't spend as much time actually thinking about the way that patients perceive urine drug screens and how those can actually be traumatizing for many patients. So they're used in correctional settings and by parole and probation in a very surveillance type way, with often punitive sanctions for positive screens. And they use clean and dirty a lot to really describe people's current substance use. And so when we care for people who have been through those systems, and we're incorporating a tool potentially to support adherence to buprenorphine or to guide pain management or to risk counsel people, we need to be mindful of the fact that that urine drug screen may feel to the patient very similarly to when parole is testing their urine. And so I really, I don't have great answers because I've discussed this with lots of people. Some people say we shouldn't urine drug screen anybody because it's stigmatizing, and if the patient's not going to tell you about it, then it's not something that you want to catch them or police them around. Other people will say you can't prescribe buprenorphine unless you're kind of confirming that it's in their urine. You're running the risk of DEA issues and things like that. It's a fraught and complicated conversation, so I don't want to tell you how to incorporate urine drug screens. I just want to say that to be mindful of things that we do as clinicians, that other people's exposure to it has largely been in a more punitive way through the criminal justice system. So incarceration, affects a lot of people, and asking about it is something that we often wonder if it's a good idea to do, how should we do it? And I just wanted to ask the audience, it's a frequent experience for people with, especially patients with opioid use disorder, and it has clear implications for people's health. So should I ask my patients if they've been incarcerated? So yes, ask all my patients during the first visit, just by a show of hands. Yes, ask all my patients, but not during the first visit. Yes, but only ask patients who I think are at higher risk. No, I shouldn't ask. If a patient wants to tell me, they will. So yeah, so this is common. There's a real mix of responses generally in these cases. Before I talk about how to respond, I just wanted to share a quick card study that was done at our clinic in 2009 in the South Bronx. I'm sort of referencing my Monty days. I don't really work there anymore, but at the Comprehensive Healthcare Clinic, they did a card study of the whole clinic. And that at the end of every visit, they asked people, do you have anybody in your life who's currently incarcerated? Do you have anybody in your life who's been incarcerated before? Have you ever been incarcerated? Are you currently on parole? And they interviewed hundreds of people at sort of just as a card study incorporated into routine clinic visits. And what was so striking was that 50% of all patients in the clinic had a loved one who had been incarcerated. And the clinic community health district or city council district had the highest rates of jail incarceration in the city. So that's, in part why. But 50% of all patients had somebody in their life who was currently incarcerated or had been incarcerated. And the third highest rate in the city is East Harlem. So the first is the sort of Crotona area of the South Bronx. The second is Mott Haven. The third is East Harlem. So jail incarceration rates are really, really high, and I don't think we fully appreciate that when we're actually working with patients, just how many people have been exposed. So asking about incarceration. So this is just my own personal kind of reflection on this. Everybody's going to approach it a little differently. It's an important part of people's lives with implications for their health. Patients may not want that to be the first thing you know about them, and they may worry that they will be treated differently if you do know that they've been incarcerated. So I sort of encourage a universal screening as part of a social history with really careful phrasing to destigmatize their experience. So I suggest as one way of asking, have you ever spent time in a correctional setting such as a jail or prison? And it really, I prefer this phrasing because it doesn't suggest they deserve to be there. It doesn't suggest that they were found guilty and therefore served time there because of a conviction. It really just identifies an exposure that they may have had. Kind of like, have you ever worked somewhere that, where you were exposed to asbestos? Or did you work around 9/11 down at the Trade Center during 9/11? Like, in criminal justice, exposure is a real health, it's a social determinant of health. And I think by thinking of it that way and asking about it, we may get, some basic information from patients. If they say yes, you can ask them to say more about it, which kind of allows them to sort of speak about it on their own terms. But it creates space. If they don't want to talk about it, you can sort of move through it, and it may give you space later to discuss it if it becomes relevant. I don't think probing details of charge is really ever important. We're not psychiatrists doing violence risk assessments. Psychiatrists that do violence risk assessments may have to ask about histories of violent crime, but we're not doing that. We're sort of in a more, in our role as primary care doctors, it's not as necessary to know the nature of their offense. And if they want to talk about it, they can share. Now, I just want to, again, just say disclaimer, this is one way to think about it. There's a lot of ways to think about this. A lot of people have asked me, should I put it in a chart? And I think that that's a different question, right? Because knowing it as their doctor is one thing, but putting something in the chart that may be visible to all providers is another. And so I would just say be very thoughtful about anything you put in the chart that you think may be viewed by others in a way that could lead to discrimination against the patient. Another barrier to care is really return to substance use. So this is just a quote from a qualitative paper by Aaron Fox, again, for people coming out of state prison. If you're away for a long time and you are coming back, many will say that they really intend to not use when they leave. And this quote was, when I was ready to come home, I wasn't thinking about getting high. That never occurred, but things happened. I came home, I'm homeless, I'm HIV positive, I have all these issues. They were beaming down on me and depressed, stressed out, I did a bag. You may know that many patients paroled out of state prison to New York City are paroled into the shelter system, which, if you could imagine, a hard place to be as somebody who's trying to not return to substance use, being thrust into sort of the busy and challenging shelter system. For many people that have been incarcerated in places where they did not have access to methadone or buprenorphine, they may be coming back to the community hesitant to go back on a medication that will result in physical dependence. And this has been shown in similar qualitative interviews where, they'll say, I haven't been on methadone or buprenorphine for years. I don't want to be, tied to that again. And they'll talk about willpower and fear of dependency. But once people, if they do use again, they then tend to have a much more open-minded kind of perspective towards restarting agonist therapy. So I would just be mindful, if you're seeing people who've been incarcerated who have a history of an opioid use disorder, sort of be prepared for them to not necessarily want to restart a medication, but to really, I encourage people to kind of lay the groundwork there and say, should you ever want to restart for relapse prevention, we will support you in helping you link into care. So you can start people on methadone or buprenorphine even if they're not actively using, right? If you're concerned about the high risk of relapse. But patients may not be ready early on, and so sort of trying to create space for that, I think, is really important. The last slide I just want to talk about really, and the last barrier, are the competing priorities of the reentry period. As we send people to IFH through some of our various reentry planning programs, you very well know that it's a time of intense change for people, especially if they've been away from the community for a while. And there's many competing priorities for people: housing, employment, benefits, family. When I made this slide, I was like, should be in the biggest font and what should be in the smallest font? Everything's sort of important and competing, but what I knew was probably should be in the smallest font is a doctor. And this is not because it's not important that they see a doctor, but for them coming out, it's often not the first thing on their mind to go sit in a waiting room and see a doctor. And so it is crowded out by a lot of other stress that they have around their housing, around the conditions of their parole, reconnecting and trying to repair relationships, making sure their benefits are reactivated. We have thousands of people incarcerated every year who are employed at the time of incarceration, who lose their jobs because of short-term detentions where they can't go back. So it's really, really stressful. And so to do this work, in my view, it's critical that we be partnered as healthcare system with reentry organizations that have deep experience supporting people with criminal justice histories. So Fortune Society and the Osborne Association are two really big and well-known and well-respected organizations in New York. that have a long history of supporting people during this difficult time. And they have all sorts of programming and resources, sometimes housing, that's often staffed by people with lived experience and that are really critical to supporting people during this time. But the way we partner as a health system with reentry organizations is really not always clear. There's really two kind of broad ways that I just want to quickly review. The first is really through something very formal, and it's really by being part of the Transitions Clinic Network. The Transitions Clinic Network is a national network of medical homes for people with chronic disease released from incarceration. And they're really, they look very much like our own primary care clinics. They just often have some dedicated faculty, a little bit of training within the clinic around caring for this population, and often a partnership with a community health worker from a reentry organization that helps with scheduling and follow-up. And those can be those are very effective models. They've been shown to increase retention and care for people with HIV and other health outcomes. But they're really the small minority of clinical spaces that are receiving people coming out of jails or prisons. We had a transitions clinic at the Monty Clinic where I trained for residency. This is Richard Medina, and he is the community health worker there, and he was at Osborne. And the Transitions Clinic really addresses key barriers during the reentry period. So you have, the barriers listed on the left. I won't walk through all of them, but the Transitions Clinic intervention on the right. And some key ones really are, the competing priorities I mentioned and sort of mistrust of the healthcare system that the case management and the community health worker can help with. In a perfect world, these places would have good access to office-based addiction, the ability to either provide or refer quickly for mental health services, training of staff around cultural humility, providing transportation for people to and from the clinic. We describe sometimes the uncaring demeanor that's often administratively in a lot of New York organizations, right? You walk up to the front desk and the person's kind of got their head down. What's your name? You're not on the schedule. It's not all places have the capacity for or the warmth incorporated into their reception, and there are people on the phones and things like that. So having dedicated people to receive the patients when they come into the clinic is really critical. The capacity to care for people without insurance, to enroll people in Medicaid, and to have really open access given the chaos of people's lives. When they're motivated to engage in healthcare, we need to find ways to get them in. And so more open access in these spaces has been shown to be helpful. But most people are not going to work in a transitions clinic, and Fortune Society, which is a large reentry organization, really appreciates that. And Michaela Linder here, who she and Richard and I have given this talk together in the past. Michaela has put together resources for providers in community settings to support caring for justice-involved patients. And so they have a reentry resource directory. It's online on the Fortune website that is very user-friendly, and that can you can search for services, you can search by zip code, but they can very quickly help providers caring for people access the types of resources that the patient's looking for. They also have a drop-in center in Harlem for patients that have needs that would be best met by an in-person visit. And so knowing where the Fortune Drop-In Center, I think, can just be really helpful for providers who are caring for people who are coming out of jails or prisons. I work for New York City Health and Hospitals, the Division of Correctional Health Services. We provide care for patients in the jail. We have a partnership with Fortune Society for people on buprenorphine or methadone coming out of the jail, and they get a peer navigator that follows them for 90 days post-release. So you may actually see people coming out of Rikers already connected to Fortune Society. So just to close, and maybe there's a little time for questions, incarceration is really common experience for people with opioid use disorder associated with many harms. Forced withdrawal from maintenance may lead people to post-incarceration aversion. Linkage to care is complicated by all sorts of barriers, including competing priorities, lapsed insurance, and stigma. Trauma history, extremely common. Building trauma-informed practice in our settings, critical to serving patients. And partnering with reentry organizations, either through a formal transitions clinic model or just through building informal relationships, is really helpful to supporting people during this time. So with that, I'll just thank you very much.
Hi. Hi. Thank you so much for coming. I'm one of the family medicine residents in the Harlem program. I've been following you on Twitter, so I'm really excited that you're here. I'm a big fan. I had a big question about Suboxone groups. I've done a little bit of research into reentry health in the past. Had a little bit of experience with Suboxone groups on my psychiatry rotation, and was wondering if you have seen any research about that being effective for people, especially since they're not really able to go to a lot of these other groups because they are on medications and they're not formally abstinent.
Right. Sorry,
Sorry, I'm a little nervous. It's nice to see you.
Oh, that's okay. Thank you. I appreciate, and I'd love to catch up more after. People on agonist therapy have been excluded and discriminated in a lot of places. NA has some formal policy that you cannot be on medication if you're part of NA, though we know that NA groups are very heterogeneous, just like other 12-step groups. So some groups are more accepting, others are less so. We know that some groups are people will hide the fact that they're on treatment, and so they'll try to get support, but they're feeling like they're sort of not disclosing something feels really hard. I could imagine that's just very hard for people to not be able to be open and honest in a mutual support group. So when I think of groups, I think often of mutual support groups, but I also think of there's actually clinical models now of dispensing buprenorphine in group settings. So in the mutual support space, there's other mutual support groups that are more open to medication, like Smart Recovery, which some of you may have heard of, that is a different model of mutual support that is more open to medication to support treatment, and doesn't invoke a higher power the same way that some 12-step groups, so it's preferable for some patients. And Smart Recovery is active in New York, and it's something that I think we probably could do a better job of connecting our patients to. But Aaron Fox, actually, and he's my mentor, so I've said his name a lot, has been studying groups dispensing buprenorphine in group settings to people that have struggled with office-based practices in the Bronx, where from 9 to 12 on Wednesdays, you drop in, there's coffee, you sit in and share your experience with some other people in the group, and then everybody leaves with a prescription for another week worth of buprenorphine. So they don't have to come sit in a waiting room and have an isolated office visit, which can be anxiety-inducing for people, especially some who are actively using. But the engagement in the group is kind of provides some support for the patient, but also a different way of engaging healthcare, and they can be transitioned into a different space after that. He's been studying that. He hasn't published on, as far as I know, on any of the outcomes of that yet, but anecdotally, he's just described that it's a model that seems to work for different patients that have struggled in other types of office-based practice.
Thank you. This was great. You've highlighted something that maybe you could respond to, which is the fact that there's mass incarceration going on. So a lot of people end up in the sort of part of the justice system really by accident or because they were discriminated against. And then there are these health issues that they have, and with the opiate problem, that there's a public health initiative, and I'm wondering, especially being part of H&H, if there's an opportunity to work with FQHCs, community health centers, those of us who sort of have been part of the social medicine history, to really take this on and sort of look at, because what you describe are sort of the very basic elements of the delivery system, but even this issue of Medicaid, this ridiculous gap that makes it's like taking away somebody's voting rights. I mean, there's just bizarre things that are happening. And is there an opportunity now to sort of convene some groups of people to get together and say, we can do better, not only just in terms of the nuts and bolts of the delivery itself, but policies and new organizations and structures. I was just wondering if you could comment on that.
That's a great question, and sometimes in the spirit of being concrete and for these spaces, I sort of try to focus in on really concrete things. Not that these aren't concrete issues, but the public health response to people with substance use disorders and mental illness and their hyper prevalence in the criminal justice system is deeply important. And I think that we, as people caring for people affected by it, have a really important obligation to speak up and to partner with patients in kind of fighting for like deeper and broader systems change. So I'll just give some personal examples of work that I have been proud and enjoy doing that I think many are increasingly doing as well. The Legal Action Center, which is a nonprofit in New York, has been systematically advocating for changes to these Medicaid restrictions that affect people. And Legal Action Center is, historically has fought for against the discrimination of people with substance use disorders, HIV, mental illness. So that work is deeply important. The ACLU and the Department of Justice actually now are bringing litigation against community institutions that are denying access to treatment for people as a violation of the ADA, the Americans with Disabilities Act. And that litigation has actually been, over the last year or so, has really gotten the attention of a lot of public institutions that has driven some change. And the third is really partnering with people directly impacted by this work. So I work closely with Vocal, Voices of Community Activists and Leaders in New York, and Drug Policy Alliance and other groups, and sort of joining them in advocating for sort of broader policy changes with respect to mass incarceration, access to treatment, and others. And I found all of those, all that work really rewarding. In terms of how do you sort of advocate as an institution, health and hospitals, we are part of something called RxStat, which is a collaborative of public health and public safety people in New York to come together to talk about the overdose crisis with monthly meetings. And I can just tell you that sitting in a room with 300 cops and DAs as a doctor caring for patients has been really enlightening. But I still think probably as a city, we've been heavily investing in funding law enforcement responses to this, and we need to have hard conversations about how that kind of focus may not ultimately serve our patients. And those are hard political conversations to have. But it's just absolutely caring for the individual coming out of a correctional setting is important, but looking at the system that puts so many people there and how do we unwind that, I think is just as important.
Hi, thank you so much for the great talk. In that same vein, I was wondering if you've seen any role for drug courts in part of that change, and if medication management has been playing a role within the drug court system.
So that's a great question. I've written critically about drug courts, so it's something that I see probably I have a biased view towards, because I generally see people who are struggling in a drug court getting sent into jail as a consequence of not adhering to sort of the conditions of the court. So just to disclose that bias, I'm skeptical of criminal justice-centered responses to complex health problems. I think drug courts are also extremely heterogeneous, and the term even doesn't often always mean the same thing. So you could have judicial diversion, where it's just a judge who is motivated to create diversionary options for people with substance use disorders. You could have drug courts, where your case is moved into a specific court that is staffed by case managers and clinicians who do independent assessments and make referrals. You could have prosecutorial diversion, where the Manhattan DA's office has a huge staff of people that actually just try to come up with diversion options for people. So drug court is kind of an umbrella term for all of these diversion options. They all, however, are rooted in a model where adherence to the agreed treatment plan and success is the metric of completion of the mandate. And we know with substance use disorders that that's basically going to mean that the people struggling the most, the ones who are sickest, the ones who have been most traumatized by prior criminal justice history are going to struggle to jump through all those hoops. And the ones that tend to do better in drug court are the young people who have very little criminal justice exposure, a ton of social support, a lot to lose. You know, you're in your 4th year at Brown, and you like all of a sudden develop an opioid use disorder, and it's like, if you just get back on track, you're gonna go to medical school or something. Like, that is a very different kind of population than heavily justice-involved people that I care for. So I see it as a limited model. I also see net widening around drug courts as that is eventually going to start capturing more and more people as a way to get people into care. I've heard this said by oh yeah, get them into that drug court, arrest them and get them in the drug court. That's a nice path to treatment for that person. And I really think that can have really dangerous consequences. So I champion something, this is all my personal views, I champion pre-arrest diversion or pre-arraignment diversion, which is kind of identifying pathways to avoid deeper involvement in the criminal justice system, sort of just continue to kind of get people towards services and a whole host of harm reduction interventions for those patients.
So I just want to say thanks. I mean, this is an amazing talk. I would like to be professorial for 1 second and just, there are a couple of things about the talk that I think everybody should notice, not just around the content, but you know, we've watched so many PowerPoint presentations. The next time you put together a PowerPoint presentation, go on and watch this again, because this is the way PowerPoint should be used. You know, not with like a million words on the slides that people are turned around and reading, but these were just so informative, so well done. I think it's a real model for that. The second thing that I noticed was, and we don't really use this enough, you had a lot of sort of qualitative quotes that really reflected like what the people's voices that you were talking about. And we don't use that enough. You know, we use like lots of results of studies and things like that, but these things don't even have to be published. We can capture quotes from our patients when we're talking about particular issues and put their voice up on the screen. And I think you did that so powerfully. So it's just a great example of fantastic combination of a social medicine kind of perspective and bringing a lot of new knowledge to folks. And I just want to point it out because I think it's just a great model for everybody. So thank you for being here. Thank you for the work that you do.
Thank you.
And we're glad that we can play a small role in this.
Great. Thanks again.